All
Perfect.
right.
Thank you.
Thank you.
All right. And we are talking specifically today about Alzheimer's disease and mild cognitive impairment. We'll really talk about what's the differences between that, but also what are the differences between normal aging as we dive into mild cognitive impairment and then Alzheimer's disease also. But for those of you who are not familiar with the James L. West Center, we are a nonprofit and we serve persons impacted by dementia. We do it through a variety of services. One of those is through the education that you are taking advantage of today. Let me silence my phone, I apologize. So the education you're taking advantage of today through our online programs, the support groups Holly mentioned, in-person programs, and we are able to offer these free of charge to families across the world. You can access us online. We are here live for our programs, but also our YouTube channel as well. We have a variety of blogs on our website. We really are here to provide education and resources for families, healthcare professionals, those that just want to know more about brain health, dementia, to help you really educate yourself. We also have residential services here in Fort Worth, short-term rehab services, a senior adult day program also. So we are here really, what do you call it, 360 care for persons that are impacted by dementia and those that love and care for them. But talking about the statistics here, and these are 2024 statistics, but still they're pretty accurate to the ones that are today. But right now there are 7 million Americans living with Alzheimer's disease and related dementias. And this number is projected to grow to nearly 13 million by 2050, which quite frankly is not that far away from where we are now. More women are impacted by this disease, but also Black Americans and Hispanic Americans are also diagnosed at a higher rate than white Americans. Several reasons for that. With women, there's hormonal changes. Women live longer than men, and this is a disease of typically the aging. The older we get, that's one of our highest risk factors. And also African Americans and Hispanics. They're not seeing the doctors as much, or they may not have access to care and getting that proper diagnosis, and also managing other illnesses that can come along and can contribute or raise our risk for dementias, which we'll talk a little bit about as well. 60% of healthcare workers believe that the U.S. healthcare system is not effectively helping families or those diagnosed with dementia. And you as a family member might be thinking the same thing. And then we have a higher incidence of people just living in community, whether it's assisted living or nursing home, that have dementia that may or may not be diagnosed. And then over half of people that have perceived memory issues or really think there's something, I don't know if this is normal or not quite so normal, but they haven't talked to their doctor about it. And we're going to hopefully dispel some things and really know what kind of questions to ask our doctor today when it comes to maybe abnormal changes that are happening, but also what does that look like in regards to mild cognitive impairment and Alzheimer's. There is a list of risk factors here on the screen. Like I mentioned earlier, age is our greatest risk factor. The older we get, the more increased our risk is. But I want you to hear me, and if you don't take away anything else from today, please take away this fact that Alzheimer's disease and related dementias are not a normal part of aging. So just because we're getting older does not mean we will get Alzheimer's disease or a related dementia. That is a fact. And a lot of people have misunderstandings about that, okay? But there are things that we can do to help reduce our risk, but it's important to know our risk factors. If we do have Alzheimer's disease or other related dementias in our family, maybe a parent or a sibling has it, this is very more complex. This is a high-level way to put this, but it can increase our risk for dementia, but it's not deterministic, okay? So if you do see it in your family, it may increase your risk a little bit, but it doesn't mean that you're going to get it. But I will also say if it's not in your family, it doesn't mean that you're not immune, for lack of a better word, to this disease. This disease is not prejudice. It doesn't matter where you live in the world, what color your skin is, how much money you make, how you eat. It will, the more we learn about it, the more we know, but it also becomes more complex, okay? Like I said, gender, more females are prone to get Alzheimer's disease and related dementias than men. If we have previous head trauma, that increases our risk. Of course, if we're abusing drugs, alcohol, if we're smoking, that's really bad for our whole body, including our brain. So really the great rule of thumb is if it's good for your heart, it's good for your brain. If it's bad for your heart, it's bad for your brain. Just think about your heart and your brain are directly connected. So anything that we do, good and bad for our heart, we're doing good or bad for our brains. So we want to make sure that we're managing any chronic illnesses that we might already be living with, making good lifestyle choices in regards to how we eat, how we move, how we manage our stress, the quality of sleep that we get to help mitigate any illness as we get older, but of course help us age with good brain health. Managing depression or high anxiety, of course, and then just those environmental toxins and lifestyle choices that I mentioned briefly. But I want to talk about, because we're saying, we're talking about Alzheimer's disease, and we will talk about mild cognitive impairment as well. But dementia and Alzheimer's disease, those words are used interchangeably all the time. Now, dementia is a general term that describes changes in somebody's cognitive abilities. So their thinking abilities, their reasoning abilities, their mood and behavior, all of these brain functions that are listed here on the screen that will interfere with somebody's ability to carry out their day-to-day activities. So that can be that short-term memory loss or memory challenges that they have, thinking and reasoning ability to problem solve. They may seem just way more confused than they have been in the past or they have been before, have a hard time getting through familiar activities, whether that's cooking a meal, doing finances, balancing the checkbook, doing your taxes, things like that, that they haven't had trouble with before, but now they might be having trouble with. A shorter attention span on things, having a hard time concentrating for long periods of time, and also noticing changes in language skills. And this is their ability to use words to express themselves, but also comprehension. So how are they understanding the words that other people are using, following a conversation or following even a storyline on television? Mood and personality changes can occur in their ability just to care for themselves. So we might see early on it's they have a hard time maybe planning out a meal or planning out their meals for the week, and it's a lot of steps involved to doing that. I got to think about what I want, what ingredients do I need, what do I have to go to the grocery store and get, and then just executing that trip to the grocery store and all the steps that's involved, coming back home, putting those ingredients together, cooking it, all of those things. So it can be complex, and we might even notice in the early stages that gets harder for somebody. To whereas if they have a progressive dementia like Alzheimer's disease, those abilities change to where they might not be able to do a trip to the grocery store or even plan out a meal, but they can help cook the meal. They can put in the ingredients. They can help stir the sauce. They can help set the table. Things like that is even into the later stages of the disease. They might just be able to smell and be involved in the meal and the socialization of the meal around the table. And then we'll also notice, which we'll talk a little bit more about, sensory input and motor output. So how are they experiencing their environment and how are they interpreting the world that they're living in? So again, dementia is this general term. And I'm going to, when we think about dementia and the symptoms that come, this is just a short list. These are the most common symptoms that we see when we think about dementia. And memory loss is listed up there at the very top. It says number 1, or they're repeating questions or telling you the same story over and over again. This is a very common symptom, especially for somebody that has Alzheimer's disease. That short-term memory loss, they're having a hard time with that. And I'm going to explain why that is here in just a few minutes. But some other changes that we see is difficulty performing your tasks. Like I mentioned, maybe it's planning out your meals. Maybe it's the finances. Maybe it's just scheduling out for the day and all the appointments that you need to keep organized and plan for. Problems with language. So they're having a harder time with their words, finding the right words. Maybe they lose some of their vocabulary, but also that comprehension and having a harder time understanding what other people are telling them. disoriented to time and place. So they might be really confused about what time it is during the day. It might even be what month it is, what season it is. I know personally we've had daylight savings this week, and my week has been a little bit off. I forgot that it was Wednesday today and almost missed a meeting because I'm just a little bit off, right? So I'm disoriented my time, but I realize that I am, and I can look at my calendar and plan out and say, okay, I got to get it together here. But somebody that might be having some abnormal changes, that confusion or that disorientation to time and where they are, and what day it is, or maybe even what week it is just much more confusing and harder for them to focus and get themselves back organized or back onto their plan. Decrease in judgment, and this would be different from their judgment in their past. So they're just making choices that they wouldn't have made in the past. It's uncharacteristic, or they're risky choices, or they're not smart choices that they would have made, of course, in their past. A hard time keeping track of things, and this is just keeping track of the day, maybe, or keeping track of the appointments that they have, things like that. Misplacing items and not being able to retrace their steps. So putting things in odd spaces, like they might put their remote control in the refrigerator. Well, that's an odd place to put that. And that generally doesn't happen. Or they lose a wallet, or they've lost their phone and they can't retrace their steps back. Changes in mood and behavior to where we might see that they withdraw socially or even inwardly, or they might seem to be a little bit more easily frustrated or irritable. And then trouble with images and spatial relationships. So seeing where I am in space and time. The example on the screen, the image there is with the stoplights. So I can see the light changing, but do I understand that it changed red or did it change green? And of course that impedes my safety. And then withdrawing from work or for some social activities also. So these are common symptoms that we see with dementia. They're not all the symptoms, right? But they're common. I think there's over 30 common symptoms that we typically see when somebody starts to have some brain changes. And it's important to see these and recognize, well, this is really different from the person, either myself or the person I love. And there's some changes, and it's more than just, well, it happened once. I missed that doctor's appointment once, and I was overwhelmed and I realized I missed it, and I could able to go back and reschedule that appointment, and I feel bad and I'm never going to let that happen again. That's a one-time thing that could have been because I was overwhelmed or I wrote it down on the wrong day. That's a one-time thing. But if we're seeing these changes repeated, and or there's a theme that we're seeing in ourselves or our loved ones, that's when we really need to be aware and really start asking questions and looking at the whole picture. So with dementia, again, it's that general term. In dementia, progressive dementia, there needs to be at least 2 brain functioning issues that are happening. So typically we see with the symptoms we just went over, especially with Alzheimer's disease, we see people that have short-term memory issues. There is a memory loss happening, but then there's also something else, and that's probably a language change, or you might notice that their mood changes, or they're having a harder time getting through the day. They just seem more confused. So there has to be at least 2 cognitive functionings that are changing for somebody for it to be considered a progressive or an irreversible dementia that you see at the bottom of the screen here. We're talking about irreversible progressive dementias that are Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal, mixed dementia. These are all dementias that are neurodegenerative. They progress over time, so they're going to get worse over time. And if somebody does not pass away from something else, they will pass away from the complications of the progressive dementia they have. Now I have on here, there's reversible dementias, or false dementias can also be another term for that. But this is something that somebody might have the symptoms of dementia, so they might have some memory challenges. They seem more confused. Their mood and personality might change a little bit. But what's causing those symptoms can be fixed or treated. So the cause of those symptoms might be a medication interaction. It might be that they're deficient in vitamins. They have an infection of some sort. But in those symptoms are caused by one of those issues that can be fixed or treated. So if I'm having symptoms of dementia, but it's medication interaction, I can get my medications tweaked and fleshed out, and now I'm on the right regimen, the right medication, the right dosage, I'm taking them at the right time. And then my symptoms of confusion, memory challenges, and mood changes will clear up or go away because I fixed the root cause of those symptoms. Now, for other people, that root cause of those symptoms will be an irreversible dementia that we have here. Now, Alzheimer's disease that we're going to dive into is the most common type of an irreversible dementia. So about 60 to 80% of persons that have dementia have an Alzheimer's type dementia. But then you can see the other more common types. Lewy body dementia and vascular dementia kind of tie for second most common type. Then we have frontotemporal dementia. There is Parkinson's dementia. There's over 100 different types of dementia, but the ones on the screen are the ones we typically see the majority of the cases. Now, mixed dementia is a dementia that's being diagnosed more and more often. And this is where somebody has a mixed picture in their brain because they might have two or more different types of dementia in the same brain. So they might have an Alzheimer's type dementia, but also vascular dementia presents in the same brain. Or they might have Lewy body, Parkinson's, and vascular dementia. All those symptoms or changes from those dementias are happening in the same brain. So it's a mixed picture, and they call it a mixed dementia. But this is a really great graphic just to help understand, okay, so dementia is that umbrella term and the different types of dementia underneath that. But dementias, they're two brain functioning challenges that are happening for somebody that interfere with their ability to get through their day-to-day life. Now, I will say fairly quickly that dementia, we mentioned, it's two parts of the brain that are going into failure or they're dying. It progresses over time. Currently, right now, there are no medications to stop the disease, cure the disease, or fix it. And we don't have any medications or any things that we can definitively say we can prevent dementia. There's a lot of things we can do that can dramatically reduce our risk, but nothing definitive that says we can prevent it. It is very individualistic. So this disease, you might have, let's say in my family, my grandfather had Alzheimer's disease and my mom had Alzheimer's disease. The same disease, but it looked different in both people. Okay, because it's very individualistic. We're all unique human beings. We all have different experiences, different coping skills, how we respond and react to things. So it will, while we understand how the disease progresses throughout the brain, how it affects somebody is going to look a little bit different. But I will say what dementia is not. In dementia, I'm saying all the dementia is rolled up under that umbrella. It is not a normal part of aging. It's not a death sentence, meaning that we can live well with, and there are still moments of joy and a lot of joy to be had, even though somebody might be living with dementia. It's not the same for everyone. It's not always Alzheimer's disease. There's over 100 different types of dementia, and it's more than just memory problems. While we start with, particularly in Alzheimer's disease, those memory loss challenges, it's more than that. It does affect all functionings of the brain. And it's not always sad or depressing, like I mentioned. We can still live well with it, and there's still a lot of joy to be had and a lot of great moments to create and memories to cherish. And it's not a thief of their humanity. So we really, in our philosophy of care here at the West Center, and we hope you adopt this too in your family or your career, that we focus on what remains. While we can see and experience what dementia does take away, we don't want to focus on that. We want to focus on what remains because dementia doesn't take away everything. And we have to pull out, we have to nourish and really cherish what remains. And on the screen is a list of stuff that we know dementia does not take away. Feelings and emotions being the most important. So that in their humanity, right? They'll always have feelings, they'll always have emotions, they'll always need to express themselves. Now, how in control they are of their emotions is one thing, but they'll always have those. And they'll always be able to create connections with other human beings, create connections within the environment, within nature, with music, with pets, always be able to do that. Personality preferences will stay with them, and they'll always be able to understand our nonverbal communication. So we have a whole several programs on communication specifically, but knowing that as communication changes, while they might lose words and lose comprehension, their need to experience and connect with other people will not change. And we generally do that through our nonverbal communication, our facial expressions, our body language, how we touch them, etc. And then, of course, there's so much more, all the abilities that remain, but that's what we really want to focus on. Okay, so mild cognitive impairment, mild cognitive impairment, or MCI, really is a diagnosis or can be a stage between a normal age-related changes that happen and dementia. So as we get older, just normal part of getting older is our memory slows down. Okay, and it becomes a little bit less efficient. What is different or what's abnormal is we start to lose memories. Normal age changes that happen is my memory's just slower. It's going to take me a little bit longer to find that word or recall what I'm trying to say, but losing a memory is not normal. So mild cognitive impairment is really that kind of gray area in between normal age-related changes and dementia. So it says, somebody has noticeable changes in their cognitive abilities that does not fall into the normal changes that happen, but it's also not severe enough to be considered a dementia. Okay, so it really doesn't affect their day-to-day activities. And I say gray area because this is pretty gray. All right, so it doesn't impact my day-to-day activities, but I am noticing that there's changes that are happening that are more than just normal changes. Okay. Mild cognitive impairment can increase your risk for dementia, for Alzheimer's disease, but it's not deterministic either. So about 12, you all see different statistics, but anywhere between 10 and 20%. I've seen people age 60 and over are living with mild cognitive impairment. And a lot of people are not diagnosed either because it is such a gray area and it is difficult to diagnose. Okay. About a third of people that have mild cognitive impairment will go on to develop dementia within 5 years or to develop Alzheimer's disease dementia within 5 years, but not everybody goes on to develop dementia. And we'll get to some of those statistics in just a second. But the symptoms of mild cognitive impairment really are that we can see somebody that has amnestic MCI. So you might notice that there are abnormal memory challenges for somebody. But there's not necessarily another brain functioning happening. So I'm just having a hard time with my memories. It's abnormal, but there's not anything else cognitively that I'm being challenged with. So I might have to use more Post-it notes. I might have to write down more notes on my calendar, use my phone more as a reminder. And it's not normal, but it's not impacting my day-to-day, and I don't have something else going on. Now, there is non-amnestic MCI that we do see abnormal changes in other thinking areas, and you can see those signs there. You might be losing things and can't retrace our steps, forget appointments, or maybe can't really stay organized, having more trouble with words than other people that are the same age, making poor decisions or judgments, poorer than I would have in the past, or having a harder time completing those familiar tasks. Now, those are the same symptoms that I talked about with just common symptoms for dementia, right? They look similar. But with this, the big differentiator between this is those signs or symptoms are not interfering with your day-to-day life. We notice that they're frustrating and they're occurring more often, and it might be abnormal, but it doesn't impact my day-to-day activities. So that's really kind of that main differentiator, and that's where it can be really hard to diagnose as well, but not impossible, okay? And that's why it's important to really talk to your doctor when you do have changes or you are concerned about yourself or your loved one, because the data shows that around 10 to 20% of people 60 or over are living with MCI. Not all of them are diagnosed. About 1 in 6 people will eventually develop dementia, so that will progress into an Alzheimer's type dementia. Okay, so some people will say it's a preclinical symptom. But about 1 in 4 persons with MCI will either stay where they're at so they do not progress, or they might even get a little bit better if they get the proper treatment, or they're treating maybe what's exacerbating the mild cognitive impairment. So they might have to change their diet and get different nutrients in their diet, or they might have to exercise more, things like that, so they can stay where they're at or even get a little bit better. So I'm going to show this short clip. It was a news report. It's from August of 2024, but it's a doctor that really explains MCI, and I like how she explains it and what the important things to look at.
At Wayfair, we get pretty excited about furniture. Around here, it's not a patio, it's patio. Oh, I love those.
Can mean signs of mild cognitive impairment, or MCI. According to the Mayo Clinic, each year around 10 to 15% of people with MCI will go on to develop dementia. And of the 8 million Americans who have MCI, more than 90% don't know it. This morning, Dr. Nidhi Kumar is on call to talk about the condition that is often underdiagnosed. Good morning to you, doctor.
Good morning.
What exactly is mild cognitive impairment?
Well, it's characterized by difficulties with memory and thinking, forgetfulness, loss of train of thought, even personality, changes, but it's quite subtle. And people tend to compensate for it. They make lists, they set reminders in their phones, and that's why it's so hard to diagnose, and it's underdiagnosed. Now, it can be caused by a neurodegenerative disorder like Alzheimer's disease, but could also be caused by vitamin deficiencies, sleep disorders, or even a side effect of certain medications.
How is a condition like this diagnosed?
Well, at age 65, part of a regular wellness check with your primary care doctor should include cognitive testing. And generally, patients are offered a questionnaire about 10 minutes long, assessing for memory and concentration. But I want to emphasize that what is even more important, more significant than any questionnaire or any testing is how you feel about your cognitive abilities. Are you noticing lapses in your memory? Or are your family members or friends noticing changes in your memory, your cognition, your ability to concentrate?
So I really liked what she said, and the importance is really being introspective on yourself, or maybe it's somebody that you love for that. But the importance of talking to your doctor about it, because most people are not diagnosed, or we're afraid to talk to the doctor. So when we are getting diagnosed for whether it's mild cognitive impairment or Alzheimer's disease or any type of related dementia, generally we get a diagnosis through a team of specialists, but it can be a neurologist, it can be a neuropsychologist, a geriatrician, geriatric psychiatrist, to really make that diagnosis. So I appreciate the doctor saying in the news clip that you can get a cognitive screening every year with Medicare. So if your doctor's not already doing that, then ask for that cognitive screening. It's important. It's part of that Medicare plan, and it can help us really understand, well, this is my baseline. If I've had one every year for the last 5 years, it's going to help me better notice if there are any changes. Okay. So starting to get that if you don't already have those. But then a doctor, a primary care physician, if they do have concerns, or you have concerns that aren't being addressed with your GP, then you go see a specialist that's listed here. And there is no single test that can be done that can tell you whether you have MCI or Alzheimer's disease or another type of dementia. It is a battery of tests. So it's a variety of tests that they're going to do to rule out anything, other possible cause that's causing your symptoms. They'll do a family history, a medical history. They'll do testing, cognitive testing, neuropsychological testing. They may do some memory testing. They'll do physical exams. They'll do extensive blood work. They may do a brain image or more, one or more, they're ruling out any other possible cause. They would probably get input from family members or close friends or family to get a well-rounded perspective on the symptoms. and then they can give you a probable or possible diagnosis of dementia. Now, the accuracy rate for dementia is in the upper 90 percentile of how accurate they are able to diagnose somebody. Where it can get complicated is maybe exactly what type of dementia you have, or if there's a mixed picture, like I mentioned earlier, or tell you exactly what stage you're in. Okay, but they're really great at diagnosing now, especially with all of the advances in our in medical treatment or medical testing now. And then we want to talk about medications, because there are medications that can help with Alzheimer's disease and mild cognitive impairment. But really, these medications and the ones listed here, these are approved for Alzheimer's disease and other related dementias. But these medications listed here, and you've probably heard of Aricept, Exelon, Namenda, they are approved to help manage the symptoms. So these medications are not modifying the disease in any way. They are just symptom management. So they help with the symptoms. They can help improve cognitive symptoms for a period of time, and they can help alleviate symptoms of maybe anxiety and depression or other things that can come along. With these medications, the key is to start them as early as you can. They work the best in the very early stages. So that's another reason why it's so important to talk to your doctor when you start to have concerns. Okay, we want to rule anything out, but we also want to start these medications because it can help people do better for a longer period of time. Now, it doesn't stop the progression of the disease. The disease will continue to progress, but there are medications that help in the early stages and medications that help in the later stages. That Namenda and Namzarac, those are the two medications that are for the later stages of the disease. The Aricept, Razidine, and Exelon are for the earlier stages of the disease. Again, these are help with symptoms, and they do vary on person to person on their effectiveness, on how well they work for each person, but it's important to really try these. Now, I do want to point out last year there were two new medications that were really transformative in the world of dementia care and Alzheimer's care. But these medications, the Kinsula and Leqembi, I think I'm saying those right. You might have heard about them in the news, because these medications are disease modifying. So these medications have been shown to clear away the plaques and tangles that build up in Alzheimer's disease. They are injectable medications. You are the side effects are pretty severe, and you have to be under a watchful eye of a doctor. So a doctor has to sign off and say, yes, that I will be on call for these medications and side effects for a period of time. And I said injectable, I mean infusion type medications. With these medications still being studied on these medications, and we really know that these work for the very early stages, or even people that have mild cognitive impairment is when they work, and they work for the period of time that somebody's on the medications. So while they might modify the disease or change the disease, we're not sure yet if it's not going to stop the disease quite yet. And there's still a lot of studies being done, but it is encouraging to know that there are new medications out there that we're seeing some changes. But still a lot of work has to be done on that. So with Alzheimer's disease, specifically, Alzheimer's is a progressive neurologic disorder, neurodegenerative, that causes the brain to shrink and the brain cells to die. So with Alzheimer's disease, you will see a decline in memory, but a decline in thinking, behavioral and social skills, and this does affect somebody's ability to function from day to day, and eventually their ability to function independently. It is the most common type of our progressive or irreversible dementias. So what's happening specifically with Alzheimer's disease is there are plaques and tangles that build up inside the brain, and I'm going to skip ahead and just so you can see this image, but there are neurofibrillary tangles and amyloid plaques. These plaques and tangles, we all have them in our brains. They're there for a particular reason. They have a function. But what happens in the brain of somebody with Alzheimer's disease is these plaques and tangles somehow become toxic. And they start to build up and create clumps. So the plaques create clumps inside the brain, and they block the communication between the neurons. Now, those neurofibrillary tangles become toxic, and they start to create havoc inside the neuron. So our neurons are being attacked from the outside and the inside, and the neurons are not able to work. They're being attacked, they're being damaged, and when that neuron cannot work, it dies and it shrivels up. Okay, very layman's way to say that, but this is what's happening that we know of so far in regards to Alzheimer's disease. We also know that there's inflammation that happens in the brain as well, and they don't know quite yet if that inflammation is helpful or if it's harmful, right? You know, we know that when we are injured or we have a wound on our body, that part of our body becomes inflamed, and that's a helpful process that our bodies go through to help us get better. But we also know that chronic inflammation can be very damaging. So we don't know if the inflammation goes to the brain to help heal the brain, but then it can't do that. And so now it's chronic inflammation. So we're not sure how inflammation plays either a positive or a negative role into the disease as well. But that is really what's happening. And with this, those plaques and tangles that build up, we know with Alzheimer's disease, this starts in the hippocampus area of our brain. Now, the hippocampus area of our brain is largely responsible for our short-term memories and our wayfinding. So these plaques and tangles start to build up and they start to create clumps or create masses. They start to attack the neurons from the inside, and those neurons are not able to connect or communicate with other neurons, so they can't work, so they start to die and wither away in that hippocampus area. And that's why we typically see that first symptom is that short-term memory loss in Alzheimer's disease, because that area of the brain is being damaged and attacked. So they are not able to remember that they just told you that story or they just asked you that question, because that area of the brain is being attacked. And I'll show you what that looks like here on this picture. And so the hippocampus is right here. You got, two of them. So right here, this is where our short-term memories largely house our ability to learn new information or record new information is right there. And if I go over here to somebody with very late stage Alzheimer's disease, that area of the brain is either severely damaged or no longer there anymore. So physically, they are not able to remember or record new information. So what we're also seeing happening is within the temporal lobes. We have our temporal lobes right here on the sides, right? Our temporal lobes, our left temporal lobe houses a lot of our language, our vocabulary, our ability to think a sentence, put it into the right order, and speak it. Our right temporal lobe has a lot of our rhythm. So this is our rhythm of speech, but it's also music, it's affirmations, it's, that rhythm that we have. So if I go over here, and this is our left temporal lobe. So when somebody is not able to communicate using their words like they used to, it's not because they don't want to, it's because they can't in that moment. Or they're not able to comprehend what we're telling them. It's not because they don't want to, but it's because they physically cannot. They're physical permanent changes that are happening in their brain. And the right side here. So you might notice that there is more or less changes that happen on the right temporal lobe. So the mnemonic that we use, and this is from Teepa Snow, is that our left temporal lobe houses our language, and we lose more on the left. Our right temporal lobe houses our rhythm, and we retain more on our right. So we lose more language on our left, but we retain more rhythm on our right. And this is important to know because somebody in the later stages of the disease may have the rhythm of speech, but they don't have words. So it can sound something like ba 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 ba. So I can tell that they're asking a question or, making a statement, but the words aren't there, but the rhythm's there. We can also always connect through music. We can connect through affirmations, those things as well. I will also point out that on the right side is where we house our special words. So those words that we don't use every day, like curse words, insults, sex talk, because it's not our everyday language for the majority of people, right? But it's on the right-hand side is where it's stored. So we might notice that persons with Alzheimer's disease are, they might be cussing a lot more. They might be saying things that are insulting. They might be using more flirtatious or sex talk, but it's because they're using what they have left. Okay, so this goes back to we focus on what remains. They're using what they have from moment to moment. They're not trying to embarrass anybody or anything like that, but they're just using what they have left. Now, I'll also point out the frontal lobe. The frontal lobe houses a lot of our sequencing of tasks, but a lot of our social graces. Our filter is up here, our ability to stop ourselves from saying or doing anything inappropriate. Social manners, things like that is up here. So we can just see the difference between the normal side and somebody that has changes from Alzheimer's disease. Okay, so they don't have the filter. They might see, they might think the word that's, a cuss word, but they don't have that filter to stop themselves from saying it. Or, they're not as in control of their emotions. I mentioned that earlier. Emotional control is up here as well. So I might get really angry about something, and I have a normal, healthy brain, and I can control my emotions. But if I didn't have a normal, healthy brain, I might get really angry. I'm not in control of my emotions, so I might lash out or hit or bite or scream or something. Now, I'm failed to say, so a normal brain is 3 pounds. Okay, so my brain is about 3 pounds. Somebody with very late stage or passes away from Alzheimer's disease, their brain is about 1 pound. So they are losing brain tissue, and you can see on the picture here that there is losses that are happening. They're permanent. But I also want you to look at this and say, well, not everything's gone, right? There's still a lot left, and it's up to us that have the normal 3 pound brain to really sit down and think and focus, well, what's still there, right? What is still there, and how can I get at and focus on and nurture what's remaining, and what they have might change from moment to moment. So here are just some common changes with Alzheimer's disease. You see that I'm going to show a short video here just in a second that really walks us through the progression of Alzheimer's disease and the changes that will happen for each, or as the disease progresses, and each functioning of the brain that it changes. But I will say it's a gradual decline. So the picture I just showed you, that doesn't happen overnight. Those changes, the 3 pound to 1 pound, doesn't happen overnight. There is a gradual decline. And from diagnosis, typically somebody will live 8 to 12 years, but people can live up to 20 years, right? It also depends on who they are as a person, how healthy they are, and all those things. Again, it's a very individualistic disease. So let's watch this 3-minute video about Alzheimer's.
What is Alzheimer's disease? Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at
That is a great summary of what causes Alzheimer's disease, but also how it progresses throughout the brain in the different areas of function. And so we can see the decline in persons that are living with the disease. Now, the next several slides, or the next couple of slides, talk about some non-pharmacological treatments that I want to end with. And then because we did talk about the medications, but I want to talk about non-pharmacological treatments just for a couple of minutes, because these non-medication treatments really are the best. They've been shown over and over again with any type of dementia that the non-pharmacological treatment should be a first treatment, and they really work the best. Now, let me take a step back. I'm not saying don't try those FDA medications that I mentioned. We really want you to talk to your doctor and get on those and try those and see, because they can be very effective. But also know that these non-medical treatments really are, they're there to help maximize quality of life and maximize independence, maximize dignity, and help somebody maintain their current level of functioning for as long as they possibly can. And a lot of this is through what we would think, well, what's our lifestyle choices that we kind of do? We want to make sure that we're effectively treating any other illnesses, whether it's diabetes or it's anxiety or it might be cancer, that we're also effectively treating those, because when those are effectively treated, then we can manage dementia better, right? We want to keep life as normal as possible. So in the next several slides that we have, I've given you kind of what to expect as symptoms occur as the disease progresses into early stage, middle stage, or late stage. And because of times, we won't go through all of those, but you have them to read. But in our early stages, we really want to focus on keeping things normal as possible and really focusing on, well, what can my person still do? Because they can still do most things. We just have to be really observed. Maybe we have to give verbal reminders, and we just have to be aware of safety, because knowing that will change over time as far as them living by themselves, managing their own medications, driving, things like that. If they can still do it, we want them to still do it, because as soon as we take away these things, they're not going to be able to do it. It's you take it away from me, I'm not going to be able to do it, but allow me to continue to do it for as long as I can. Or I might even have to modify the activity a little bit, but I'm still part of it. So I can continue to keep those skills, right? So our 3-pound brains really have to educate ourselves and build our skills on, well, how do I modify these activities so they're still, life is normal. We have joy, we're keeping in those hobbies, we're adding comfort. In the middle stages, we want to start adding more support, not just for the person with the Alzheimer's disease, but support for that caregiver or yourself as well. And a lot of this, you can do these the same, what's our exercise routine? Are we up and moving? Are we, getting enough blood flow and oxygen to our hearts and our brains? What is our diet? I'm not saying we have to go on a strict diet, but are we feeding our bodies with the appropriate fuel to help us just feel better? When we make good choices in regards to our health, we feel better. And when we feel better, we just do better. That's the same no matter what kind of illness that we're living with. but also keeping cognitive challenges, being cognitively stimulated. So there is people with dementia can still do a lot of things. They can still be in activities. They can still be a part of music. They can still do cognitive exercises, and really thinking about exercises or activities that are familiar, that are fun, but that are purposeful, so that we're meeting, because we want them to know that they're still part of the family, the community, they still contribute, because persons with dementia are grown people. They've lived long, responsible lives. They have people that rely on them, and we need to continue. That's just part of being a human being, and continue to have those activities in their lives that give them a sense of purpose, that they're able to give back, whether it's cooking a meal to volunteering in the community, and what that looks like, even though they're living with dementia potentially. So the next few slides, again, I mentioned, do break it down into common symptoms you'll see in the early stages, but we want to keep things normal. Common symptoms in the middle stages, adding that support, because in the middle stages, you'll have more pronounced changes. And then in the late stages, and of course, late stages is adding that sensory and that comfort care, and knowing that this is time of maximum need. So at this time, there will be 24-hour care for somebody with Alzheimer's disease, but this lists out the common symptoms that you can expect in the later stages of the disease. And then talking about the theory of retrogenesis. I'm going to give 1 minute on this. And this is a theory about really focusing on how do I pull out what remains, and how can I focus on what remains. So in this, and I'll give you in the follow-up email, I'll give you a full-size sheet of this so you can actually see it. But on the left-hand side, you have mild, moderate, severe, early, middle, late stage. It breaks it down into the fast staging tool, and this is a 7-stage staging tool that doctors may use. And then it talks about skill level and clinical characteristics in that third column. And these are just common clinical characteristics that you'll see as somebody progresses through the stages. And then you'll see those last two columns there about the developmental age and abilities and skills. And that's where I want us to focus. So I'm trying to make it a little bit bigger here. But if we have somebody, let's say it's our loved one that might be in the early moderate stages of the disease, or stage 5, I can see some clinical changes. Now, please know, not everybody fits perfectly into a box, right? But what we're looking at here is, so if somebody's operating in this stage of the disease, then it's like they're operating on the same developmental level as a 5 to 7-year-old. Now, please hear me say developmental level. We're not talking about they're acting or behaving, or we treat them like a 5 to 7-year-old. We treat our persons with dementia like the dignified human adults that they are, always. No ifs, ands, or buts. But developmentally, they might be on the same level as a 5 to 7-year-old. So I have to ask myself, well, what can a 5 to 7-year-old do? Gosh, they can do a lot of things. They're dressing themselves. They're making a lot of decisions. Now, they're not driving, right? Or they're not managing medications, but they can go and pay for, if I give them the money, hey, go up there and pay for these groceries. Or they can follow a list, they can follow instruction, they can do a lot of things. And so that's where it helps us as care partners to step back and say, okay, how do I maybe simplify this activity, or how do I modify it so it matches their abilities? Instead of taking it away or doing for them, I want to modify this to help match what their abilities are. So again, I will give you a actual sheet that you can read in the follow-up email, but I want you all to focus on that as your, another takeaway from today on, well, how can I focus on what remains in my person? It's a lot of information that I didn't even get through all of it in 1 hour, but you have the slides. You have both mine and Holly's contact information if you have questions going forward. But Holly, was there anything that we needed to address that I didn't get to, or were you able to answer stuff?
Yes. Yes. I was able to answer everything, I believe. I don't see anything else unless somebody has something. We are right at time. We're glad you were here today.
Yes. Yeah. Look for that follow-up email this afternoon. I'll give you the slides. I'll let you know when this is available on YouTube. I'll make sure you get the information on our upcoming programs and support groups. And I appreciate y'all sticking with me in this fast and furious program. So Thank y'all so much. Have a great afternoon.